Washington University's Public Policy and Economics Institute. Speaking as a Spokaneite, I don't know if you realize, but we have broken 2 records weather-wise in the last 2 weeks. We had the largest snowfall ever in the history of Spokane in September, and we had the largest snowfall ever in the history of Spokane in October. So I don't see much of the white stuff down here like I see around my home, and it's really nice. I was telling Carol this morning, I brought my bike down so we can actually do some biking, because that's been a little difficult where I live in Spokane. So today, I think everyone has an agenda, and I think you have a sense of what we're going to do, but we are going to get a checkup, a report out, taking a pulse of our local health improvement networks. And for those of you who have been with us a while, and I just thinking about this, Carol, I think we've been doing this now for 5 years, right? 2014 is when this started. From the very beginning, there's always been a concern about the central point of view of what kind of actions we take as a 9-county region, and what could be done at the very local county level or sub-regional level. And so out of that discussion, this notion of local health improvement networks was born. And I don't know whether the other ACHs have something like this. Do they? County. Okay, but that's only one. So we feel pretty good that there's been, some funds allocated. I think 1.2 million for the LINs, and Ruben has had that on his, part of his job description. And he's telling me before we started that he's really enjoying going around and seeing what's happening at the local level, and excited to hear what is going to be reported out today. So what we're going to start with is just a panel discussion by the six representatives of the LINs, or representatives of the 6 LINs, and that will be followed then by some highlighting of some of the funding that's gone on to the various community-based organizations in our region. So as we like to do, I'm going to start by asking for introductions, and I'm going to start with the back row. I don't know why Wes is in the back row this time, but we'll start with you, Wes, and if you wouldn't mind just speaking up so everybody can hear you. Yeah, good. If we got a traveling microphone, all the better.
Good morning, everybody. Welcome. I am Wes Lucky. I'm the Deputy Director for the Greater Columbia Accountable Community Health.
Hi, I'm Norman Thiel with Sunbridge Community Center in College Place, a grantee out of the Blue Mountains.
Kendra Palomares, Catholic Charities, Healthcare Transformation Director.
Tim McGuire with Columbia County Health System in Washington.
Rachel Gass with Greater Columbia ACH.
Carol Moser, Greater Columbia ACH. Becky Gould, Greater Columbia ACH.
Diane Taylor, Greater Columbia ACH.
Kurt Williamson, Benton Franklin Community Health Alliance.
Larry Yankee, Health Officer, World War I Columbia.
Rachel Anderson, Garfield County Transportation and Aging and Disability Resources.
Martha Lamb, Columbia County Public Health and Garfield County Health.
Chelsea Eaton, Columbia County Public Health.
Marty Linder, Walla County Public Health.
Christina Rodriguez, Columbia Basin Health Association.
Ian Middleton, Columbia Basin Health Association. Leanne Turnbull, Southeast Washington Aging Long-Term Care Local Program Coordinator and Superintendent's Office.
Megan Fulmer, Tablet Community Health.
Shauna Banner, Lewis Medical Center. Robert Reed, Lewis Health.
Karen Clark, First Step.
Penny Bell with Ideal Balance.
Laura Ray Walsh, Pullman Regional Hospital Strengthening Families Coordinator.
Becky Heifel, Whitman County Health Network.
I'm Roseanne Tucker with the Three Rivers Community Foundation.
Carla Crocker, Benton Franklin Health District.
Ronnie Batchelor, Lord's True Blood Outreach Program.
Sierra Foster, Astrea Health.
Diane Conklin, Jackson Neighborhood Health Services.
Lisa Hester, Yakima Neighborhood Health.
Jocelyn Pedrosa, Yakima Neighborhood Health.
Michelle Sullivan, Yakima Neighborhood Health.
From Yakima Neighborhood Health Services and Board Chair of GCACH.
Good morning, Lindsay Boswell, the Yakima Valley Community Foundation.
Hi, I'm Nancy Riggleman from Valley Residential Services in Walla Walla, and we're a grantee through Blue Mountain Community Foundation.
Jenna Shelton, Greater Columbia ACH.
Martin Sanchez, Greater Columbia ACH.
Martin, Kittitas Valley Healthcare and Kittitas County Health.
Lauren Noble, Greater Columbia ACH.
Chelsea Chapman, Greater Columbia ACH.
Have one person that
Loretta Alta, Greater Columbia ACH.
Where did the person who just came, just like to stand up and shout out your name and serial number? Oh, there's another one.
Mary Isaacson, Blue Mountain Community Foundation.
Welcome. All right, and we have quite a few people on the phone, Chelsea, so why don't we go and have those people introduce themselves. Can you identify them, and we'll ask them in turn so we don't have a free-for-all? Or do we have to have a free-for-all?
Free-for-all.
Free-for-all, okay.
Oops, let me unmute them.
Those of you on the phone, would you mind introducing yourself and the organization you're with?
Judy Miller, Columbia County Health System.
Judy?
Molly Shute, Prosser Memorial Health Clinics.
Thank you, Molly.
Bill Dunwoody, Catholic Clinic.
Lindsay Ng, the Health Center in Walla Walla.
Okay, Lindsay? A few more?
Jolene Carper, Tri-State Memorial Hospital.
Thank you, Jolene.
Jorge Rivera.
Jean Merle Family Learning Center.
Thank you, Jean. Jorge, did I hear you?
Sir.
Is that it? Anybody else online? On the phone?
Deb Watson, Pullman Regional Hospital.
Is that Deb?
Yes.
Thanks, Deb. Thank you for participating, those of you on the phone. I know sometimes it's a bit of a drive to come to the Tri-Cities, so we appreciate your participation, and we hope that the ACH's new sound system will make a difference. It's certainly making a difference for me already. I can hear much better with this phone than the phone we had over at CBC. So let us know if you're having problems following the conversation, and I will ask when we get to the Q&A from those of you around the tables, which we hope there will be quite a bit of. I would just ask you to speak up out of courtesy for those on the phone. So with the first panel make their way to the front here, 6 of you, and you will be introduced by Ruben in just a sec. Any quick questions about the agenda today before we get going? All right. So Ruben, the floor is yours.
Well, welcome everyone. Thank you for being here. I'm very excited about this meeting. I'm really looking forward to see all the hard work that's being done out there. GCACH awarded $1.4 million to spread throughout our county region so that the local health improvement networks could identify any social determinants of priority in the regions, and they also picked a third-party administrator, and that will be the next panel, the third-party administrator. But the local health improvement networks went through a process that included getting the consumer voice on what social determinants are priority. And based on that, the local health improvement networks picked their priorities and handed them out to the third-party administrators to find organizations that can address and help mitigate the effects of social determinants of health. So we have here a panel, first of all, of LIN leaders or LIN representatives. That's what we call local health improvement networks, LINs. So they're here to just like last year, tell us about how the activities, what's been going on with their local health improvement network, what kind of events and activities they've had so far, anything that they're working on currently, and any plans for the future. So they will talk about that. Each of them have a presentation, and I think we're going in the order their names appear on the agenda, right, Chelsea? Mm-hmm. Okay, so I'm going to go ahead and just, they introduced themselves already, but if you don't mind really quick, tell us your name. Start over there with Becky, your name, and which local health improvement network you're representing.
I'm Becky Heifel with Whitman County Health Network.
Kirk Williamson, I am the thorn among the roses this morning.
Morgan Linder with Blue Mountain Regional Community Health Partnership.
Kevin Martin, I'm board chair for GCACH County Health Network.
I'm Rhonda Hoff. I co-chair the Yakima County Healthcare Coalition with Dan Ferguson.
And Martha Lamman, Southeast Washington Health Partnership.
Okay, so let's go ahead and get started with presentations. And I think Kirk Williamson goes first from the Benjamin Franklin Community Health Alliance.
Thanks, Ruben. Let's just go ahead and move to the next.
There is a clicker
slide.
right there for you.
Oh,
Whenever
way uptown.
we're moving on up.
The Health Alliance started about 25 years ago as to be a neutral convener to bring our hospitals together, particularly, and other providers to work together. And that continues to be a significant part of our mission. We've also become the LIN for Benton and Franklin counties, and we also spend a fair amount of time and effort supporting our community initiatives, including providing a 501c3 status as an umbrella for some of the organizations, and our insurance covers some of them, and our CPA helps provide financial stability to some of those organizations that are that we umbrella. We started out this year. This is the year we need to do the community health needs assessment and the community health improvement plan, and that's been a good part of our focus with our 4 hospitals in Benton and Franklin counties and the Benton Franklin Health District. We have had the benefit of some technical assistance from Providence has really made that work for us. We've been able to do bilingual listening sessions in English and Spanish, a number of interviews with leaders in healthcare and human services. We wanted to make sure that we were hearing all the voices, and that's one of the things that maybe was a little bit lacking in some of our previous efforts. We were able to reach out and reach some voices that we hadn't heard otherwise, and then the usual number of data sources that we all found. And the Alliance used some of the money that we received from the ACH as thank you gifts or inducements in the form of gift cards for people who took part in our listening sessions and some of our other work around the CHIP or around the CHNA. We had qualitative surveys and lots of data points. We also added qualitative analysis, which I think was really important. And if you have an opportunity to do that as you do your own CHIP and CHNA, it's really valuable. Providence helped us through Catholic with, we were able to record our sessions and have them analyzed for keywords, body language, emphasis, a lot of things that you might not expect otherwise. What we learned...
Not working?
Not working. The innate back one.
Back one?
Yeah, there we go. Okay. The innate perversity of inanimate objects. What did we learn in this community health needs assessment different from the others? is we focused on behavioral health, which is not brand new, but only in the last round did we go through that. Access and cost of care for everyone, both physical health and behavioral health, is a huge issue. And interestingly enough, the more we worked on it and the more we talked to people, the more we were focused on social determinants of health. And that will be a big issue for us as we produce the Community Health Improvement Plan. Next slide. The CHNA was approved last night, as a matter of fact, in our meeting, and we're really pleased about that. So we'll get started, next slide, on the Community Health Improvement Plan. Now that we know the needs, we're going to be starting to look for achievable and measurable improvements. Those things will be important, and our relationship with the ACH will be important to help make those things happen. Under the next slide, please. So we will support a number of local programs and initiatives. We've taken the Youth Suicide Prevention Coalition under our wing, under our umbrella, and also the Human Services Coalition, which is about 20 years old in our community, but has been separate. We see the tie-in with social determinants, and we will continue to work on that relationship, and they will be the pointy end of the stick for really trying to get to issues around social determinants. One more slide, please. The other thing we did that we've taken some statewide leadership on that we're really proud of, a year ago our state senator came to us and said, this is in August, and said, I want you to spin up a 24/7 confidential tip line for middle and high school students, and I want it working by December so we can take it to the legislature. One does not say no to Senator Brown very easily, but three of us ganged up on her and got it done. We held a community safety summit about a year ago that resulted in a really strong recommendation that she was able to take to the legislature. We produced a white paper that is on our website if you want to take a look at it. I think that is used now in both in the legislature and in the Attorney General's office and other parts of state government to look at several states that are using this particular format, a 24/7 confidential tip line, using all kinds of different ways to reach them. We used Michigan as a model, and Michigan gets lots of, they use text, they use Snapchat, they use every platform you can imagine, and some people actually even call them, but that's where I'm in a different world. There's the second annual national conference is in Reno next week, and I'm going to go see what I can learn so that we can work in Washington to do the same thing, because Michigan in 3 years had 16,000 tips on everything from bullying to suicide to the kid building an arsenal in the basement to food insecurity to housing, to you name it, and they've had calls about it. We think it's really important, and our alliance will continue to support that, and we use your money to do it, Ruben. Thank you.
Good, that's what it's for. Can we move on to the next? Rhonda, you're next. Rhonda is with the Yakima County Healthcare Coalition.
Oh, thanks, sir.
As Ruben said, this is the second year we've done this, and conveniently, Mr. Ferguson has been out of town. Give me the date for next year. I'll make sure and get it on his calendar. Or I'll be out of town. So the Yakima County Healthcare Coalition was founded in 2002, so we've been around for quite a while. And originally, when our group started, it was also at the behest of one of our state representatives. So interestingly enough, her name was Mary Skinner, if any of you are around or remember Representative Skinner. But really, at the time, our purpose was to address legislative issues that affected the disproportionate number of Medicaid and uninsured residents of Yakima County. So our mission and our charter hasn't changed a whole bunch. And at the time, we spent the majority of our time developing white papers specifically to speak to the legislature from a unified voice. So we, at the time, had a series of white papers ranging on everything from Medicaid eligibility, the basic health plan, pharmacy issues. There was a brief period of time, if you remember, when our state actually had co-pays for Medicaid beneficiaries. So we took up those issues, nursing home issues as well. So that's sort of how we got our start. You can see here, hopefully you can see this, but we have a little over 30 organizational members. We meet twice a month. We meet in person, and we also have go-to-meeting availability. And the go-to-meeting option has increased our participation because some people don't like 8 a.m. meetings, particularly the fact that we meet on Fridays. So we have really good participation. We've got community health centers, we've got the legal community, hospitals, nursing homes, social service organizations, colleges, good representation, particularly because we talk a lot about workforce issues. So we have a lot of participation from lots of different sectors. Okay,
Presentation.
All right, thank you. Okay, so earlier this year, we did just a quick member survey to talk about how we wanted to spend our time and what our priorities were. And again, some of this is Dan's influence, as well as Keith Minoski from Pacific Northwest University. But a lot of our topics have really centered around interprofessional networking and patient care teams. And that's what the green bar is along the top, is it's asking the survey members on the things we wanted to talk about. So the other top issues here related to cultural competence, racial equity, but the number one choice was interprofessional teams. And so a lot of our topics around our agenda have been built around these kinds of issues. So this is just an idea of what some of our topics have been talking, or what we talked about so far just in 2019. In the first quarter, we were focused on healthcare access and coverage. In Yakima County, or in Washington State, and some of this, I'm sure you're all probably involved in this as well. You know, in Washington State, we've enrolled over 200,000 enrollees or re-enrollees in the Washington Health Benefit Exchange. In Yakima County, that's 13,000 just in our county alone. And just kind of FYI, since the implementation of the Affordable Care Act, this has impacted almost 200,000, or a little over 200,000 people in Yakima County between Medicaid and the exchange. So we are, eternally grateful that our state adopted Medicaid expansion. We talked about the impact of integrated managed care in our county, and then also we lost one of the managed care organizations, and so just helping patients maneuver that and make those changes. And then again, we've had several discussions about collaborative practice and interdisciplinary care teams and how that works in our community. It's one of the really good things about a community our size is that we really have great relationships across organizations and sectors. And then also we've spent a fair amount of time, quite a bit of time, talking about patient self-management. And one of the things many of our organizations have in common is really trying to get more patient engagement and getting patients more involved in their own care. And so we've had discussions about wellness management and patient engagement, and specifically around the Insignia product, the PAM screening tool, which I'll talk more about in a minute. We have talked about the hub and spoke model for behavioral health and the medication-assisted treatment program that we have active in our county, diabetes prevention programs, and then also just recently we've had a really great presentation by Columbia Legal Services on medical legal partnerships. Sort of the next thing, I think, for a lot of us as we've worked really hard on behavioral health primary care integration, getting a legal minds and part of the interdisciplinary team, we think is the natural next progression. So this is, if you're not familiar with the PAM screening tool, this is One of the things that came out of our discussions about getting patients better, more engaged, is we really started talking about how we could expand the use of the PAM screening tool. A couple of organizations, Comprehensive Health Services, Catholic Charities have been using this quite extensively. Those of us that are health home programs have been using this with the health home patients. But we talked about how, what this might look like if we could use it with larger populations. And so we've had several discussions and presentations from Insignia. And then last month, then we talked about doing a pilot project with our LIN funds to help, because it is quite expensive, to help expand this with different populations, other chronic conditions, our medication-assisted treatment patients, to be able to use this and expand this. So 5 organizations in our county are going to pilot this for the next couple of years using the PAM tool. And if you're not familiar with it, it uses coaching and motivational interviewing to support patients in their ability to make health decisions, self-manage chronic conditions. And then ultimately, we hope to impact healthcare utilization and reduce unnecessary costs. And then the heart of our coalition meetings, every topic we end with brief and sassy updates, and this is where all of the members can share really what's going on with their organizations, any local trainings and changes, and any program offerings that they have. And I think a really good example was when Columbia Legal Services talked about the medical legal partnerships and what they were hoping to do. And as a result of that, within our organization, we partnered with them, and we've had 2 pop-up clinics so far. We've got the 3rd one scheduled, where their staff come in and meet with our patients. We do a lot of social determinant screenings, and so our providers, our case managers, and our care coordinators are in great positions to identify consumers that have legal issues or have health conditions that could be impacted if they had some legal guidance. And so those have gone very well so far. We're hoping to do that on a regular basis. At the presentation, Bonnie, the attorney that did the presentation, shared with us that on average, and there's a needs assessment that the state medical legal partnership conducts, and their assessment said that for low-income families, that on average, low-income families have 9 social determinants that can be impacted with legal counseling. So, I mean, it was amazing. And I can actually share the slides with anybody that wants them, but it was a great presentation, and learning from each other and what resources they have has really made a difference for us. Okay.
Thank you, Rhonda. One thing I forgot to mention, the presentations are 10 minutes, and so far we have been within the 10 minutes. If you can keep an eye on Chelsea over there, she's going to give you a signal that you have 3 minutes left at the 7-minute mark. But so far, so good, okay?
You guys are doing great.
Okay, next is Dr. Martin from the Kittitas County Health Network.
Morning. Morning. Robin Reed is our executive director. She likes this slide because she likes to say that our job is connecting silos. I disagree with that. Grain in a silo does nothing. Our job is blowing them up. We are a 501c3. We've been incorporated for 2 years. We grew very organically, but the vision and the mission has been pretty consistent. We want to make sure that all the people in our county are supported. We grew out of caring for people that not only had fallen into, but in many cases fallen through the safety net. Our mission is to improve population health through collaboration. To that end, one slide ahead of folks. We also went through the Community Health Assessment, Community Health Improvement Plan process. We completed that in 2017 and adopted the CHIP as the strategic plan for the health network. It gives us a single overarching view. It gives us a benchmark that we can measure our efforts against. It was an interesting process. It was long. It was involved. At the end of it, we did a celebratory dance, the cha-chip cha-cha. But we came up with 3 strategic goals out of that: improving delivery, addressing social determinants and upstream factors, and sustaining collaboration. And many of you have heard our history, but the 10,000-foot overview, we had a perceived crisis. A bunch of folks got together across agencies to address what was thought to be 60 people displaced from skilled nursing facilities by the closure of the facility. It turned out there was one individual that we couldn't find a replacement for that wound up in assisted living briefly. But the people who came together found that they were dealing in their day-to-day work with a lot of the same lives. And so they started meeting weekly back in 2015 and have been meeting every Tuesday ever since. And at some point, somebody had the idea that we probably ought to find a way to make that sustainable rather than relying on the goodwill and indulgence of employers and participants. And we started formalizing our network structure. So that sustainability piece has been kind of a thread that's run through the work from the beginning. So from an organizational standpoint, we have the network intended to address the broader picture and to function as a convener. The origins, the care coordination group that I mentioned, was the A team, which you see down here now as a task force off of the care coordination work group. To support that, we've, with the support of GCACH, been developing and piloting a digital health commons, which is a mechanism where people across agencies can share information and referrals about individuals. Some of the work that we've done has involved as arranging for somebody to be placed in guardianship and placed in a safer environment. A lot of it has been as simple as building ramps and getting access. One of the things that we've found as a frequent identifier of people that need our services is the number of EMS runs they make without transport. And we've had more than one individual now that was calling EMS 6 times a week. And it turned out that they were going to dialysis on Monday, Wednesday, Friday, and they needed somebody to get them out of the house and somebody to get them back. That's not a good use of resources. And that's one where we can intervene. So we made a referral to the high school shop class. They built us a ramp. So with the digital health commons, what we're hoping is that we'll be able to make that referral without sharing PHI that the kid on the bandsaw doesn't really need, but share a picture of the house with the dimensions where we need the ramp to go. And have that kind of interchange be 2 ways so that it's both an intake. Years ago, the public librarian came to us and said, I need to be able to send people to you because the homeless show up on my doorstep every day, and when I'm missing, I'm the first one to know it. That's the kind of I don't want to say on the ground, but more like looking up at the top of the grass. But to support that, we also have an opioid response group, a behavioral health group, which has about 60 regular participants at this point, a resilience task force, ACEs and resilience, a data analytics group, because we recognize that if we want to make this sustainable, we're going to have to demonstrate value, and somebody's going to have to want to pay us for it. We are now starting to get some outreach where we may have some sustainable funding to work on some of the high utilizers. The support we're getting is hope will increase the bandwidth of the A team, the base care coordination group, from about 15 individuals at a time to 200. It's a broad partnership. Up there, these are all people that have been involved in our board of our leadership group with CMCOs. You see law enforcement, education, employers, healthcare systems, mental health providers, comprehensive does most of the work in our county. Valley Psychological Services does most of the Medicare work. Oddly enough, those tend to be the people that the A team intersects with. One of the interesting health indicators that Kittitas County leads the state in is we proudly have the highest rate of uninsured in the state, which presents challenges of its own. Who have I missed up? Substance use. FISH, the local food bank. Hope Source deals with those with housing insecurity, transportation issues. It's a really phenomenal group. The A-team started with about 8 agencies. There's 31 on this slide. Those are represented on our board. We have the current mayor of the city of Ellensburg, the school superintendent. I'm board chair. My CEO is our treasurer. It's kind of nice. These are little rumors. What have we done? So our leadership group, we've had 75 participants. That's a typo. That should be, I read that. That should be 31 network partners, not 21. We have 2.2 full-time staff. Is this slide up? Yes, we have our third staff member there. We've gotten 11 grants totaling about $1.75 million, mostly for work around substance use, a lot of it coming from GCACH around substance and around social determinants. We talked about the health commons. The A-team so far has touched about 150 lives over the last 4 years. We have no shortage of referrals. They've ranged from people who were basically living in storage containers that were half buried to individuals in assisted living to students in dorms. We have had multiple meetings around 9 different convenings around the CHA and identifying needs in the community. 10 active work groups. We talked about the health commons, and we're rolling out more. One of the biggest single grants that we've gotten was a $1 million 3-year implementation grant to draft around the hub and spoke model a local substance use treatment for merit comprehensive. So going forward, I may have mentioned sustainability. Meaningful community engagement, I think, is our water. Planning, communication, measuring ourselves, expanding the health commons. Our behavioral health group is very eager for us to be able to roll that out so that they can have access. A CHIP update, the next full update is due in 2022. And locally, we're hoping that our county government, which it can do by fiat, will enact a 10% sales tax to be used for behavioral health and mental health. The nice thing in our county is that a sales tax is a pretty easy sell because by 90. And so if we can just convince them that they're taxing the people of Seattle rather than the people of Seattle. And with GCACH support, we've been able to engage in training and sponsoring events. Additionally, ACH has supported our members in practice transformation. So we are grateful for the support of this group. So our social determinants project involved Hope Source, FISH, and Meals on Wheels. And we're now at the point where we're hoping to be able to have medically appropriate diets delivered to people suffering from disability. I think I pushed them on time.
You were right on time.
Thank you, Dr. Martin. Next up is Martha Landman from the Southeast Washington Rural Health Network.
Morning. Good morning, now better? So in Southeast Washington, our challenge in our area is that we have 3 counties together with our land money. These are the 3 courthouses in the 3 different counties. our Southeast Washington Health Partnership started about a year before we had the Lynn organization. In May, we meet monthly in Garfield County at the Nazarene Church. So it's a little unique meeting space. These are some of the partners that meet on a monthly basis. We also have aging and long-term care that comes to the meetings. We have Chaz Health that comes, and transportation that join our meetings every month. Jack Davies from Spokane comes down and facilitates our meetings for us. It's very beneficial. And we also have the go-to meeting or the Zoom so people can call in, which is very handy, especially the next 4 months when we have snow. There's a couple mountains to get over to get to Pomeroy. These are some of our past activities as we've done a community health assessment for each county and across all 3 counties. So we compare all 3 counties together, and that's been a real benefit. Out of that, we are starting to work on our assessment, and these are the top 5 things that have come out of our assessment that we're progressing towards to go for our community health improvement plan. Healthy kids, telehealth, community-based care coordination, transportation, and insurance navigators. And you'll see these come back when we talk about our community health dollars and how we spent those. We'll fit into these areas. So one of the current things that we're working on now in our meetings is we just received a federal HRSA grant. So geared towards rural health. And this grant, we're talking about telehealth, and we're talking about care coordination. This will also help us, it's a planning grant, so it'll also help us pull our network together, define our network, and we're hoping to go for a 501c3 and formalize our network operations. And I think that'll be a real benefit of this grant. So we're working on the community health improvement plan. We have Steve Smith from Spokane Regional Health District coming down and helping us in our monthly meetings and to facilitate the community health improvement plan process. And then we're working on the community health funds and just keeping track of those. And engaging new partners. They're finding the gaps in the communities, finding common gaps across all 3 communities, which is a little bit more of a challenge sometimes. Pomeroy is real rural, and so we're finding some gaps in Pomeroy that we're using, and Dayton has the means, or Stoughton County does, but because Pomeroy is so rural, they need a little work there. But finding those gaps together helps us all help each other in those things. Collaborative efforts. One of the things we found when we're working on the HRSA grant already, we're just in the beginning, couple of months stages. One of the things we found with our telehealth, one of our challenges might be our broadband system, which we're thinking telehealth, and we're trying to figure out how to fix the health system. And we haven't even got to the stage of, wait a minute, am I going to have internet access to these people in the country? And so it's kind of took a different direction all of a sudden. It's very interesting to bring that out. So these are our community health funds. So we did it, we split the money up into some different categories. One that I thought was real important was an insurance navigator in each county. So funding for an insurance navigator in each county. We had some people volunteering and doing that, but to be able to get the training from Tri-Cities Community Health here in town and to have their support behind them and to get funding in each county for these activities was really important. And they're just completing the funding now because that starts here in the next month or so. We also have transportation funds in each county for medical appointments. So they have to show us their driver's license and insurance, and have they tried to use public transport, because we do have public transport in each county. Have they tried to use it and it doesn't fit into their schedule, or maybe they have to go to Spokane and there's no public transport that goes to Spokane, then we can give them gas cards. I just had somebody come in my office yesterday and get $60 worth of gas cards because they had an appointment Monday in Spokane with their baby that they weren't going to be able, they were going to have to cancel. So it's very nice to see the rewards of our community health dollars at work. We also got a transportation bus for Columbia County Health Systems in Dayton. And we're also using some of the money for mental health services that has been successful in our school to really be able to focus some money there. And in Garfield County, we did a survey and to our community through National Night Out. We did a little 4-question survey and it came back that there's no fresh fruits and vegetables at the food bank. And it's really hard to access fresh fruits and vegetables in Garfield County, even at one local grocery store. And so that was one of the things we used money for at the food bank, is to be able to get more fresh fruits and vegetables in. I think that's a real benefit to that community, to have that access. And I just want to mention again, Jack Davies from the Northwest Rural Health Hospital Network. She has been beneficial and really helped us to move our path along. Thank you.
Thank you, Martha. Yeah, Jack Davis, she's a great facilitator. She's even come down here to help with the efforts on the community health needs, right? Okay, next up is Morgan Linder from the Blue Mountain Regional Community Health Partnership. That's Walla Walla. And Colby County.
So I'm Morgan Linder. I work for Walla Walla County, and that is kind of what our partnership is housed under. And we're, like Southeast Washington, quite a bit younger than a lot of the other groups on this panel. But as I said, we serve Walla Walla and Columbia County. We have 93 participants on our roster right now from a wide variety of sectors in the community, and we're currently working on expanding that, trying to figure out where the gaps are. Here's just a little bit of overview of what we've done in the past through our community health assessment and community health improvement planning processes. We started the community health assessment process and realized that there were some other groups in our community looking for similar data. So we collaborated with them to maximize the resources, and we went through a process of bringing a lot of different people from the community together. We put together some preliminary data and then brought it back to the community for feedback, polished it up a little bit, and then produced a final report. And our final report included a little bit more health-specific data than what we gathered during that community feedback process. But it covered these 3 areas: social determinants of health, risk factors, and health outcomes. And then we moved from the community health assessment process into using that information for our community health improvement plan. And this process started with bringing together a select steering committee from our health partnership to lay the process out, figure out what would be best for the people in our group, because we have a lot of busy people and it's hard to get people to monthly meetings consistently. So we decided to distribute a survey that took participants through each section of our community health assessment, gathering feedback about what should be a priority for our plan and what work is currently happening in our community for each area. And this all resulted in a final chipboard session where we determined our final priorities. And I took that information and put it into our final chip report. These are the 3 priorities we selected. At that work session, we also decided to utilize some existing efforts in the community. And there's a lot of talk already around early learning, behavioral health, and housing. And these are the 3 groups that were assigned with coming up with specific strategies for each of these areas. And we also did a consumer survey to figure out priorities for community health funds. We offered $5 Walmart gift cards for participants. We sent it out to partners. We gathered feedback from both Housing Authority and the Walla Walla Clinic, and then we did in-person collection at the food pantry. And we didn't get too much new information outside the community health assessment, but it did confirm that some of the data we were seeing from resources was what people were experiencing in the community. And these are the final social determinants of health priorities we landed on. We changed the behavioral health one to reducing barriers to healthcare just based on some of the other challenges that consumers are running into. And this was decided mainly through just discussions at meetings. It's not too different from what we decided through our extensive community health improvement planning process. And we passed these on to our third-party administrator, Blue Mountain Community Foundation, who also distributed the funds for Southeast Washington. And these were the projects they selected, which you'll hear more about on the next panel, I think. And this is just an update of where those groups for our community health improvement plan are now. Our early learning coalition has already determined their priorities, and they're getting ready for implementation. This is probably because they were already an existing group. They have additional support financially and some technical support because they were selected as an early learning community. Our Behavioral Health Council is just coming together. That was our main priority, was really bringing people together because the biggest challenge was just aligning all of the work in our community. So they're actually meeting right now, talking about some indicators that they can look at moving forward. And our housing priorities will be completed in December in the form of our 5-year housing plan. We've also recently identified a chair for our meetings so that it's more of a community effort instead of just a county effort. We switched to quarterly, longer meetings instead of our monthly meetings because we realized there was not a lot of progress being made in between the monthly meetings. We might change that depending on where we end up in the implementation phase farther down the road. And we are a little bit more focused for each meeting. So we will include a kind of detailed local update, regional update, and presentation from a local organization or provider. And the last one was for behavioral health. Moving forward, we of course will be implementing our community health improvement plan, and we'll do like an annual kind of check-in of where we're at with that. As I mentioned before, some targeted outreach to bring more people to the table and make sure that we have a really wide variety of sectors. And strategize to bring some of those organizations receiving the community health funds to the table and how we will utilize the training fund. Right now, we want to use that for some behavioral health training in our community. We have a lot of ideas. We're trying to figure out what will fit best into the policy for the training fund. But behavioral health is, of our 3 chip priorities, the one that we think needs the most financial support at this point. And our region has used some of the sponsorship funds that are available through GCACH. They are really good examples of how GCACH's funding is helping support some of the behavioral health work that's already happening. The first one took place in August. It was for National Night Out. We were able to distribute 90 medication lockboxes to members of our community. And in order to do that, they had to fill out a survey. We're still waiting on some of the data back from that, but it'll give us information on the community's knowledge about suicide prevention, means restriction, and locking up medication. And these are just some of the organizations that were involved in that. So it's a huge effort, very collaborative effort within our community. And we're able to generate a lot of interest in some of the behavioral health efforts and start some conversations about where people second event funded by the sponsorship fund was Your Suicide. I think there's a little blurb about this in your meeting packet. But we brought Dr. Justin Coffey to town to talk about his methods, tools for suicide prevention. And this included 2 provider-specific presentations with families and a community roundtable. We were able to have some really good conversations, and I think we got a lot of providers educated on the topic. If you want any more information about our community health improvement plan or the sponsorship fund, anything else we're talking about, go to our website or contact me.
All right, thank you, Morgan. Last but not least, we have Becky Highfield from the Whitman County Health Network.
I'm going to take the microphone out so I can turn and look at my slides while I make sure I don't miss anything.
Like Ruben said, I'm Becky Heifel with the Whitman County Health Network. We're located in rural eastern Washington.
Right above Garfield County. Idaho.
The Whitman County Health Network was created in 2014 from a HRSA planning grant that we received.
It brought together a lot of different constituencies in Whitman County in both health and human services.
I really saw a need to coordinate efforts. There was a lot of duplication of services,
and we felt like we really needed to come together all around the county to eliminate those duplications and provide more coordinated care. So these are our members. The CEO of Pullman Regional Hospital, Scott Adams, serves as the chair of the Whitman County Health Network.
and we have, sorry.
Need some water? Okay, I think I'm good. Sorry. We have the other hospital in Whitman County, as well as the primary care.
I've been fine like the whole morning. Both hospitals in the county, as well as the primary care clinic. We have Community Action Center, Whitman County Public Health,
and some of our newer members are Yakima Valley Farm Workers, which I'll talk about in a minute. We have Police Psychiatry and Behavioral Health, Police River Counseling, and so you can see all the other members there. So out of that HRSA grant, we completed a needs assessment back in 2015. And out of that needs assessment came
the need for more oral health services, access to affordable health care,
more services in the mental health area,
and food insecurity. Those were the top needs
that came out of that community needs assessment back in 2015.
So the Whitman County Health Network kind of took a look at that
data and said, okay, what can we do now to address these needs that our community members have stated?
So we have worked with the Yakima Valley Farm Workers who have recently, I guess it's been almost a year now, in November. They opened a new clinic in Pullman that primarily serves Medicaid families. So that was a huge improvement in our area because most of our dental providers were either capped or no longer taking Medicaid patients. So we now have clinics that service those families.
We began looking at how we could integrate team-based care. We started in a couple of our primary care clinics having behavioral health providers integrated into the clinic. So they were actually based there either for a few hours a week or a day a week or a couple days a week to integrate those services and to provide a more
team-based approach. Recently, we have partnered with some of our other social services or social service providers in the county and have supported the On the Move project through the Whitman County Food Coalition and Food Tables, and they are trying to provide mobile food clinics or mobile food banks in our rural areas. So our outlying areas, again, like Garfield County, have said they don't have fresh fruits and vegetables. They don't have access to them, which is somewhat unreal, considering the area that we live in, and we're surrounded by agriculture and farmers and tons of fresh fruits and vegetables and wheat and lentils and peas. And so it's very unfortunate that our outlying areas do not have access to fresh fruits and vegetables. So the Whitman County Health Network has provided some funding to the Palouse Tables Collaborative to get these mobile food banks up and running so they can take fresh fruits and vegetables to the outlying areas. One of the other areas of need that we saw in the area was around mental health. I think everyone up here has also stated that. So one of the projects that we took on, we partnered with WSU, Washington State University Extension, and implemented the CLEAR project in one of our elementary schools in Pullman. This is a program to address ACEs by providing trauma-informed practice. The Train the Trainer program, where they come in and they provide the training, and then those individuals can train others in the other schools. And right now this is being expanded within the school district in Pullman. And then we have some other, another program that we're implementing that we'll talk more about later. And then recently, we were able to do another community needs assessment. We put the survey out in 2018 using the community improvement funds, and just now getting our final report back on that. But kind of the cool thing about us having these now 2 community needs assessments is we were able to partner with the Innovia Foundation, who received a grant to do a regional needs assessment in the 11 counties that they serve. And they actually used our survey as a basis for their survey so that we can compare data among all 11 counties. So we are working on that. They're just completed their survey and also just getting their data kind of back and reporting out. So that's been an exciting development. And I don't know if I should talk about this now or later.
Later, on the next panel. Yeah.
Okay. So Whitman County Health Network, like I said, has been around for a few years now. We are currently, I would say, kind of expanding our programs, and we've recently invited new members to participate in the network, and so it's been very successful. So, thank you.
I don't know about you, but I was just so happy and impressed to hear all these wonderful activities, and I hope you are made aware of there's a real strong pulse of lots of grassroots activities in our GCACH, which was really the intent of the LINs. And of course, LINs can't, ACH can't take credit for this because a lot of this was going on before the LINs, but hopefully the LIN money has helped catalyze this. So could we give our panelists a round of applause? We have a few minutes for questions. If you would like to just pose any question to anybody, please go ahead and do so. While you're thinking about that, I'll just say we see some commonalities here, and we see some differences. We certainly have a great variety of size, ranging from Southeast Washington to 28,000 to the Tri-Cities of 300,000. But I see some common threads. All of you in these areas have engaged in health improvement plans. All of you have developed a need assessment and then followed by a health improvement plan. You seem to all be doing something in the area of behavioral and substance abuse. You seem to all be working in some social determinants of health, which I find interesting because that's something we at the ACH sort of broader level have not been able to do much, but you're doing that, and I find that commendable. So, but there are some differences, and we haven't heard much about transportation issues perhaps from the Tri-Cities as we have in a very rural area. So I don't know what those of you in the counties that you live in might be inspired or intrigued by some of the projects that are going on, but if you are, we've got about 5 minutes, 7 minutes before the next panel starts. So any quick comments or questions? Okay, Ronnie? Yeah, it's dangerous, I know. So we only have 7 minutes.
Perfect. So, Dr. Martin, I'd like this question to go to you. In what I was listening to, you had stated that you were the highest non-insured county.
Right.
And can you tell me what that contributed to? And the other piece of my comment would be, I applaud you for the collaboration you're doing with many.
Well, same thank you on behalf of all those people who are collaborating.
I love that.
Yeah. We really don't have a great sense. I think there's two things that work. The first is that our county is very, very red politically, and there are a lot of people that won't touch anything that smells of the Affordable Care Act. The other thing that we think is playing into that is we have a very bimodal distribution of wealth. So we actually have a significant part of the population that probably doesn't need it. There's some properties in Kittitas County that are owned by CEOs of large Seattle software firms. So we think that that's actually skewing the numbers somewhat. But there's also a fair number of people that just simply don't take advantage of anything.
Okay, thank you, Kevin. Other questions for the panelists? Certainly, some of these projects must have piqued your curiosity about how they got started, how they're working, where they may go. Any other thoughts? All straightforward.
Well, you think of a question. I have a couple of your LINs higher than Lois, right? With state employees, with not only with GCACH money, but maybe from the grants that you've received. Can you tell us what they do with those positions?
For us, we have an executive director, a program coordinator, and now a program manager. That is, the program manager is specifically from one of our grants. But they function as both as facilitators for various meetings, leadership groups, work groups, and there is some clerical work that needs to be done to support. On an ongoing basis, our board is looking at which members are in a position to benefit the most and perhaps pay for membership in the network. And make that kind of the price of being at the table so that it is truly sustainable. We agree. KBH sees enough value in the network that we have our CMO, our CEO, social worker, our ED department manager, our ED department medical director, all participating in the network. So if we're going to give that much time, it stands to reason to see value. Probably support the network. And the network will be asking other partners to step up as well.
Anybody on this side of the table want to respond to how you've spent money on staffing or have you? No. Okay.
Morgan, I believe your LIN is using some of the GCACH funds to pay the coordinator, right?
Yes. So it's not supporting my position full-time, but as assessment and communication coordinator, it fits really well in with some of the community health assessment and community health improvement planning work. So it's 6% hours.
All right. We're going to have Carol just make a couple of announcements as we're transitioning to the next group of panelists. So again, I want to thank all you panelists for your reports. I'm inspired. I hope some of you are, if not all of you are. So thanks once again. Ms. Moser, you have something to add to this?
I have a microphone too. So one of the things that I wanted to do is just, first of all, thank Patrick. He's been here from the very beginning, facilitating our first meeting. Actually broke his neck on the way to one of our meetings way back in the day in Walla Walla, and he's still here, thankfully. We talked a little bit about the genesis of each LIN, but really what brought it all together was our Regional Health Improvement Plan. And our Regional Health Improvement Plan has been our North Star for Greater Columbia ACH. And it identified early on the importance of having community collaboration at the local level. So we really looked to the LINs to create this community vehicle for uniting voices. And it's really based on the model of what's called collective impact. Collective impact is a model that addresses complex social issues from a cross-sector perspective. And what I'm so delighted with is that you see all of these different organizations and the composition. They range from fire departments, local government, social services, food banks, just a collection of agencies that come together to solve these problems. Granted, $30,000 a year for each LIN is not a lot of money. It's not meant to support a full-time staff, but we felt like it was enough just to kind of help get these kinds of initiatives off the ground. And you've heard Rhonda talk about using some of the money for implementation of the PAM scoring, the patient activation measures. So we're really interested to see how these funds are used in the community, because we do see networks as a theory of action. In fact, networks in and of themselves cause things to happen. And for that $30,000, it's just not free money, but the LINs have to have certain deliverables. So one of them is quarterly meetings with Greater Columbia ACH staff, sharing their rosters and meeting minutes so that we ourselves can expand our membership list. In fact, Patrick challenged us to double the number of members that we had in our Greater Columbia ACH distribution list this year. And then we are currently working on forming a local health improvement network with the Yakima Nation. So hopefully we'll have one more LIN by the end of the year. But anyway, I just wanted to thank everybody for sharing your LIN stories with us this morning, and we look forward to the next panel.
Thank you, Carol. So will the next group of panelists come to the front, please?
So now we're going to have the third-party administrators come join us. There are 4 of them, maybe 2 per table, so that one person doesn't feel too lonely.
Anchor this thing.
10 minutes per? Okay. I'll give you a 3-minute warning.
Carrie,
there she is. Okay, so just really quick again, we allotted $1.4 million out to the different LINs in the 9 counties, and they selected the social determinants of health priorities within their regions. And they also selected a third-party administrator from within their region to administer those funds for these third-party administrators to find organizations to do that work to mitigate the effects of social determinants of health. So we're going to do the same thing again. Each third-party administrator has 10 minutes, and within those 10 minutes, we would like for them to talk a little bit about their organization and to talk a little bit about the work they've done with our funds or with us, in their partnership with us, and also point out any grant recipients that they have within their regions, point them out here, and those grant recipients, I just made up a word. And those grant recipients, they'll have an opportunity, a couple minutes to describe the work that they've been doing. And we understand that some of you just got your money, some of you just got selected, so you might not have a lot to share on what you have done already, but maybe what you are working on or you will be doing in the future to mitigate the effects of social determinants of health. You know, one Ben Franklin area, probably just this week, they selected the grant recipients. You're probably not ready to divulge the names because you probably haven't notified them, but maybe you can touch on what areas they're going to be working on. So we're going to do the same thing we did before. Introduce yourself, which organization you're representing, and then we're going to start in the same order. We don't have a presentation. Just tell us about your organization, the work you've done with us, and then point out your grant recipients, okay? So let's go in the order that we have you here. So Roseanne, you want to start?
Start. Okay. Well, I'm Roseanne Tucker with the Three Rivers Community Foundation. Here we go. And we got our money, but we just finished our interviews just a little over a week ago. And to give you just a little bit of background on Three Rivers Community Foundation, we've been around a while, and we're transitioning now, where there's been some changes in our organization. But in the midst of all this, we got this wonderful grant, and it was, we were really thrilled to receive it. On an annual basis, we distribute grant funding to local nonprofits in our Benton Franklin areas. We normally get 50 to 80 applicants. And unfortunately, our pot of money isn't large enough to necessarily provide a huge impact to some of these recipients, but our full board spends a lot of time and effort in vetting all these organizations and trying to do the best we can with the amount of money we have. One thing that we always come across every single year, I've been there 6 years now, is we'll have a grant applicant come in, and what they're asking for, the next grant applicant that comes in is very similar to what they're asking for. And we run into this continually, and later we don't just write checks and mail them to these grant recipients. They have to come to a grant ceremony where we actually hand them the money. And one of our hidden agendas with that is we want to get them all in the same room and actually communicating with each other. And what we're finding is a lot of these organizations have no clue who the staff is in this organization that's doing similar work to this other organization. So if we can bring those people together, we feel like we're doing a service in our community. And that came to light again with the grant money we received on the social determinants of health. There again, we saw some overlap. However, what actually really pleased us in a couple of the applications we received is they walked in with 3 partners that they identified are going to help them distribute the funds. And that was like, wow, okay, we're making some progress in this town. So we feel like there's a huge opportunity in our communities to spend time on collaboration. And I think it has to be, unfortunately, dedicated time that somebody needs to take the charge. And I'm probably speaking for my whole organization, but I think we need to be pivotal in all of that because we do hear the needs, and as well as a lot of you do. So I'm excited about that piece of it. The criteria that we received from the Benton Franklin Community Health Alliance was housing, mental health, and food insecurity. Greater Columbia. Sorry, Greater Columbia Community Health. The criteria came from Benton Franklin Health Alliance, correct? And out of the applications, I would say 80% is going to go to housing and mental health. And we will be making the final determinations actually either tomorrow or Monday, and we'll be ready to give out the distributions. And we haven't decided yet if we're going to do a ceremony type thing where we actually have them come. And we were thinking about maybe come to one of the sites that we are going to help fund. We haven't thought that through, so I'm open to any ideas if any of you have, things like that, or if you just do it in your normal grant cycle. So that's what we're all about.
Okay. Thank you, Roseanne. Well, you don't have any recipients to point out.
I don't. I would love to have had a couple of them here today.
Yes, the next third-party administrators do have a couple recipients to point out, and they will have an opportunity to talk a little bit about their work they're doing. So next up, we have Lindsay Boswell from the Yakima Valley Community Foundation.
All right. It's very intimidating with this microphone up here. Okay, is this on? Yeah, okay, good. All right, so, good morning. My name is Lindsay Boswell with the Yakima Valley Community Foundation. I'm one of our program officers there at the foundation. And before I get started, I want to just recognize a new colleague of mine who's here, Estacio Beltran, who's right in the back there. He's our program officer working with our health and wellness initiative, so you will see him in this group more often soon. I think he's on like day 15 or something on the job. So we had the pleasure of serving as the third-party administrator for both the GCACH County Health Network and the Yakima County Healthcare Coalition. So we're really delighted to be able to contribute to community-based work across two areas. And so what I thought I'd do is I'll share a little bit about our community foundation and how some of the genesis of where our origin story is connected to health and health outcomes, and then share a little bit about how we did the work for both GCACH and Yakima Health Coalition. So we are a healthcare conversion foundation, and there's a couple other of those in the state. The Empire Health Foundation and the New Group Health Foundation. So for those of you in Central Washington, that came from the sale when Sisters of Providence owned St. E's Hospital in Yakima and the Toppenish Hospital. Proceeds from that sale helped create the operating endowment for our community foundation. But because of that genesis, part of our discretionary granting and investment in the community is always going to be about health outcomes. And so when this partnership opportunity came along, it's a really wonderful fit with a core part of the mission of our organization and the work we're trying to serve. And when I get to talking about the work in Yakima, I'll also highlight a little bit of how we were able to use a fund that we have at our foundation that we call our Health Equity Fund, that actually came about as the result of a settlement for charity care from some previous owners of some of the hospital systems in our area. And so we were able to actually do essentially a match for funding in Yakima, which we were really delighted to be able to move on those funding streams. And so I'm going to talk about our work in GCACH first. So we were able to help support the GCACH County Health Network in their process. We are inherently less connected to GCACH than we are in Yakima because we are located in Yakima, but we try to do as much work as we can in supporting philanthropic and grant and community-based activities up in that area. So we were really honored to be asked to serve in that role. You've got kind of a one-page document that describes a little bit of that grant in progress. I'm trying not to read it because inevitably the moment you hit print and distribute it to a large group of people is when none of the math works and all of the spelling is wrong. So, but that should give you a little bit of a snapshot of the grants that were awarded there. And we experienced a really nice alignment of some of the objectives that we were looking to influence at the Community Foundation with both GCACH County and Yakima County in converging the focus areas. So we at the Community Foundation, we've got a Health and Wellness Advisory Committee. They had, through their own process, had landed on 5 different focus areas that they had wanted to do work in. We were able to line those up both in Yakima and in GCACH to figure out some areas that have overlap. So in GCACH, they were focusing on institutions around housing justice and nutrition. And the grantee that was selected actually does both. I noticed, okay, I lied, I was reading it and then I stopped. So under focus area, that one should be both housing justice and nutrition. And I am not sure that, this is when I was going to pitch it to Susan from Health Source, and I don't think she's here. So, scanning, just reading.
No, she's not.
Okay, thank you. So there's a brief description here. I can't comment more on the work they're doing because I trade in all the grants we do at the Community Foundation. Oftentimes I know just enough to be fun at cocktail parties, but I can't tell you exactly all of the details of it, so I won't try to surmise on the ones in GCACH in particular because we are a little bit less connected. But again, we were really honored to be able to help do that work up there. So
I'll pause there to see if any of the other Kid Test folks wanted to comment or share anything about that process.
I think Dr. Martin stepped out.
Okay.
Maybe when he gets back, he can.
Okay, someone remember that he's, circle the floor back. Okay, so then I'll switch a little bit to the work in Yakima County. And again, just reiterating that we were really honored to be able to participate in this together and really delighted that we were able to leverage the GCACH funds with some of our own health equity funds and some of our distributable grant income to essentially match the funds that came from this. So we were able to do multi-year grants and match. And so that is truly what we are trying to do as a community foundation about aggregating philanthropic resources that we can collect. So we were really pleased to be able to do that. And so this has a whole slate of all the awards that we made. Not all of them have GCACH funding attached, this one that doesn't. But and then there's a little page summary of some of the different grant programs that are there. And we had a couple of different grantees lined up for today. One of them is Rod's House, which does tremendous work with youth experience homelessness. But they are not here today. Did the baby come? Oh. So the executive director's wife is having a baby we're all waiting. So he ended up not being able to join us today because I didn't want to be responsible if he was here. I needed to be there. So perhaps at a future time you can hear from them because their work is really incredible. But there's a little summary here. So the other grantee that we wanted to give the floor to is some of the work that's coming directly out of Yakima Neighborhood Health Services, and then, Yakima Neighborhood Health Squad is here today. They also are the fiscal agent for one of the other projects, which is a home road center in Yakima County. So I'm going to stop for a second. To Rhonda, I think, who's going to talk a little bit about those two projects.
So, yeah, thank you. So, our organization, the Yakima Neighborhood Health Services, was funded to expand our medical respite program. And I've talked to this group about it before, so just briefly, medical respite is recuperative care for people who experience homelessness, who are either not quite sick enough to be in the hospital, and for those who are coming out of the hospital and not well enough to go back to the streets. We've had this project since 2007. Last year, we saw 78 unduplicated people in our medical respite program. Their length of stay averaged just under 20 days. That was the good news. The bad news was we had to turn away 48 people because we were at capacity. So fortunately, with the advent of this grant, we had a home that we were able to convert to house 5 people at a time. And so it opened in July, and so we are very grateful to the foundation and Greater Columbia ACH to be able to support that. For the Homeless Network, we have identified 3 or 4 different varieties of shelter in Yakima County that accommodate people for short periods of time. One of the challenges that we've had is that depending on the needs of the people in shelter, and medical respite is actually considered a form of shelter, is that people get sanctioned out of shelters for different reasons. Lots of times it's mental health related, sometimes it's physical disabilities, but we want to do a better job of coordinating who we refer to which shelter. And so the IRIS project, and IRIS is an acronym that I cannot tell you what it stands for. But basically, the shelter providers are beginning to, we're trying to standardize a referral process and better more efficiently refer people to the different shelters, developing sort of a mini intake and assessment form so that we can agree on trying to help people find the best fit for shelter purposes for them. And then I can talk briefly about Rod's House, because I co-chair the Youth Coalition with Josh, who conveniently is trying to have a baby. But Rod's House is a youth drop-in center, and part of the project that the Youth Coalition has been working on is to develop an overnight shelter for youth and young adults. Currently, we have a shelter that we support for 18 to 24-year-olds, but we don't have anything for anyone under 18. And so part of the project that Rod's House is working on is looking for a shelter and support services for youth that are under 18.
And I think the only thing I would add, thank you, Rhonda, for filling in all of the buckets there, is that the grants we made in this round are what we call our strategic grantees. So they're multi-year grants, and we're trying to build partnerships with those grantees without overburdening them with reporting requirements. You know, there are no reporting requirements for other funding sources that you do. So we try to do, and it's coming up here at the end of the year, we go out and have a conversation and do an interview where we spend time interviewing the grantees, and then we write the reports for them, send it back, say, you know, make sure this is accurate. But we're trying to shift some of that burden to us instead of the grantees. We've done it one whole year, so we've got a little bit of practice, but this will be the second year around. But so probably by first quarter of next year, we'll have a really nice suite of reports that we'll be able to share back that have some more information and updates about the work.
Thank you, Lindsay. I'd like to point out on the other side of the agenda, you have a full list of grant recipients, except for the Franklin area. We're still in the process of selecting them. But also at the end of this panel, we're going to have some time for questions and comments. And we're going to have some time also for some networking. I know some of you already, if you hadn't thought about it, you probably want to talk to somebody you see on this list, or we're already looking forward to meeting someone. So there will be time for that later on, okay? So we're going to move on to Carrie. Carrie, I want to say, my instinct, my first language wants me to pronounce your last name Isaacson, but it's probably not like that, right? It's Isaacson? Yeah, okay. So Carrie is from the Blue Mountain Community Foundation.
Thank you. And I am really happy. I've got a number of people who are grant recipients through the Greater Columbia ACH, and I'll introduce the people shortly. So I've been with the Community Foundation for 4 years, and as you know, the community foundations are tied or principally serve a geographic area. So we principally serve Umatilla County in Oregon, Columbia, Garfield, and Walla Walla County in southeastern Washington. And then, like every community foundation, there's like each. So we also have groups in Fulton County and groups in Benton County that we work on in other parts. As a community foundation, we're primarily a source of private support. So working with GCACH was wonderful for us, and also helped connect us and educate us more about what's happening with health, very broadly defined. We love the social determinants of health. We love that approach. That's connected us and made the rest of our grant making much more effective. We have assets. We're growing all the time. We have assets of $51 billion. So for a rural area like southeastern Washington, that's not so bad. We distribute $2.8 million a year, about $700,000 in scholarships, and the rest go out to nonprofits. And so we had 2 GCACH grants. And the first one covered the Stoughton, Garfield, and Columbia County, and the second one was Walla Walla and Columbia County. And they had overlapping but not identical goals. And so the grants we made covered behavioral health, they covered transportation, fresh food, basically emergency assistance for people whose health would be significantly compromised if they didn't have some resources for non-health things, pay rent, fix the car, other things, so that they can make appointments and get to the doctor. In rural areas, especially Columbia and Garfield, transportation is a huge issue, and so we were happy to support vans as well as gas cards and other support there. I'm going to introduce Nancy Riggle from Valley Residential Services, Norman Thiel from Sunbridge, and Lindsay Eng, if you're still on the phone, from the Student Health Center, can also share something about their grants and the use of the money.
Hi, my name is Nancy Riggle. I'm from Valley Residential Services, and I'm wearing my love shoes today to tell you that I love the fact that you've given us funding for something that is really hard for our agency to fund, and that is a wheelchair accessible vehicle. We have a large supported living program that we support 73 people with intellectual developmental disabilities in their own homes in Walla Walla. And if you've ever purchased a wheelchair accessible vehicle who has $50,000 for the van and the wheelchair lift, we are so cheap that we tried to cheap out in years past, and it does not work, especially for people in power chairs. And in supported living, we feel like people need to be in their own homes from the time they're referred to our agency until the time they pass from our agency. So that has meant that we've had to really struggle to come up with funding for those kinds of important things. So I wanted to really tell you I love that you did this for us, Carrie Isaacson, and this group here. It's very important to the needs of our clientele. And our clientele are, they don't access even regular wheelchair accessible units very well because of their challenging behavioral issues, because of their intellectual disabilities. They need a lot of specialized transportation, so I'm very grateful and I appreciate it very much.
Answer over there, sir.
Hi, I'm Norman Steele with Sunbridge Community Center. We're located in College Place, that serves the Walla Walla College Place area. We have a dental clinic there focused on serving Medicaid clients. And the funds have enabled us to expand our services. Unfortunately, with reimbursement rates, every additional person we serve, then we're losing more money. So your support is very helpful and brings oral health, which is very tied together with overall body health in our area. So the support has really been invaluable and helps us to make a commitment to greater hours of service in our area. So thank you.
Thank you. You pass the microphone over to Shane McGuire, please.
I'm sorry, Shane, didn't see you.
I'm Shane McGuire. I'm with Columbia County Health System. Through other GCACH efforts, we've been expanding services to include integrated models of care like behavioral health and wound care. And what we discovered is access isn't enough. 35% of the patients that had behavioral health appointments were missing their appointments. And when we dug deeper into it, we found out that transportation was actually becoming a barrier and a hurdle to people making their appointments. And things like behavioral health and wound care, missing appointments can lead to bad outcomes, certainly in wound care. And so we challenged our community health workers to help diagnose this issue. They began transporting patients, and one of our vans that we had for local transportation only, it had 230,000 miles on it. The air conditioner worked sporadically, and you almost had heat. And so one of the things that we did is we approached Carrie early on, even before the GCH funds were in her ability to distribute. And she got us connected with other funders, and we just made the decision that we would take whatever funds we could get from those funds, and then we would augment it ourselves, which sometimes for organizations like us means a little bit of a Sophie's choice. What am I going to not do in order to do this other thing? And so when the GCH funds came in, Carrie was able to leverage the fact that we serve both Walla County and Waitsburg, Washington, and Columbia County. We were able to take advantage of both of the funds that she had available. We have the entire cost of the van covered. The interesting thing about this van is it has a gurney capacity, and it's for the wound care patients. They transport better lying down sometimes. It's not a mobility thing, it's a pain thing. Sitting down on wounds can be very painful, especially if you're going to specialist appointments 2 hours away in a van. And so we are very, very appreciative of the funds, the way the funds were distributed. The application process was something that wasn't overwhelming or daunting for us. And again, we appreciate supporting those programs.
Martha, can you touch on a little bit? I know you already spoke to some of the things Columbia County got.
Sure. We also have Rachel Anderson here from the Department of County Transportation also. So we talked, the transportation I already talked about is across all 3 counties with gas cards for medical appointments. The other one that Columbia County Public Health got was the insurance navigator and funding for that. We've been doing it in Columbia County, I'm sorry, I got to figure out which hat I got on. in Columbia County for a couple of years, and we've seen a difference. We have people that see Shane's community health workers at the hospital, and then they get in the car and come to public health and sign up for insurance. We also started in Columbia County that fits into the insurance is we do basic food. So the basic food person walks in the door for basic food. Oh, while you're here, do you want to sign up for insurance? Would you like to sign up for WIC? Okay. They come in for insurance. Oh, would you like to sign up for basic food? Would you like to sign up for WIC? In a small community, to have that access all in one place is a win-win-win. So I think that's a good example of how to find it.
Rachel?
So I'm also from a small community and I wear many hats. I'm the general manager for transportation and the information specialist for aging and disability. So we've got two of the grants. One is the gas cards that we do for all 3 counties. So, and I know just in the last 2 weeks, we've helped someone that got in a very bad L&I accident have to go to Spokane for treatment and not have any money. He was a Medicaid client, low income. A lot of our jobs in our communities are low income. And he was able to get to Spokane. Another one, Medicaid client came in actually yesterday and her appointment is tomorrow in Spokane. Well, trying to get on the SMS to talk and get it approved in 2 days is pretty much not feasible. So we're seeing more in Garfield County. I know that Martha's handling Columbia County and they're using it as well. The second one we're doing, so I handle a lot of crisis situations in Garfield County. I do food stamps for anyone that walks in. We team with Blue Mountain Action Council for energy assistance and rental assistance. If someone walks in and they need help with one thing, like Martha said, they can get stamps. I can help them apply for Medicaid. And now Navigators. So instead of calling and waiting 45 minutes on the line with the client, I'm now going to be able to go in and log in and help that client right away and not take up so much time. So thank you very much.
Great to see you, Rachel. Is there anyone, another grant recipient in the room from either one of the southeastern counties?
What about Lindsay on the phone?
Yeah, before we go to the phone. Okay, over there. Yeah, before we go to Lindsay on the phone.
I'm Shannon Jones from Sutton County, and we too were recipients of a $15,000 grant for navigating training and implementation. We've gone through the training with the folks in Pasco. We have a very, very excited staff member engaged in this and is ready to really get the ground running, bringing not just over clients, but going to providers sitting in their offices, working with them to coordinate those efforts, making sure that we're in the colleges, going to the hospitals to make sure that they're available. So we're also very appreciative of that. We have to have that really robustly in our community, so she's going to do that. Please.
Thank you. Martini, we can bring the microphone. There's a microphone. Okay, Lindsay, can you go ahead and share with us what you're doing with the funds you received?
Hi, good morning, everyone. My name is Lindsay Ng. I'm the Executive Director of the Health Center in Walla Walla. We are very appreciative of the funds we've received through the Community Foundation and GCACH. We're a school-based health center, and we have 4 clinics in our schools in Walla Walla. We're in 1 elementary school, 1 middle school, and 2 of the high schools here. And we provide medical and mental health services to students free of cost in those schools. On staff, we have 2 mental health counselors at each of those schools and 1 care coordinator. And then we have rotating nurse practitioners that work a couple hours a week at each of those sites. And we received funds for general operating funds, and that is so important to us. Like I said, we have 2 mental health counselors that work at each of the schools, and we do bill Medicaid for those services provided. However, the care coordinators play a really vital role in addition to providing administrative support, such as scheduling and hall passes and communicating with the schools. They also address the social determinants of health for these students, which really supports our students from a wraparound perspective, but also allows our mental health counselors to really practice at the top of their license. So our care coordinators are that friendly face that the kids see first when they come into our offices, and a lot of times through conversation, the care coordinators learn what's going on with these students, if they've got food at home, if they have a place to sleep, and then can kind of help provide those wraparound services, and then also talk with their mental health counselor and let them know some of the information they've learned that may not have come out in those therapeutic sessions. So they really work in tandem to provide those wraparound services. And unfortunately, our services for care coordinators are not reimbursable through insurance until we can change some policy at the state level. So these general operating funds are really important to help us provide those really critical services to those students. So thank you. We really, really appreciate the support. We couldn't do the work we do without this funding. So thank you.
Thank you, Lindsay.
I had a couple of other things, Ruben. I'll be quick.
Yeah, no problem.
Couple of our other grant recipients couldn't be here, but one of them, it was Doug Johnson, superintendent of the Dayton Public Schools. They lost an administrator, so now he's also principal of the elementary school. So, that's a good reason not to be here. Anyway, the Dayton schools in the biennial student climate survey show that Dayton was doing pretty well, except on a couple of mental health issues, one being bullying. And so they have used, he sent me a report, in the short time they've had the money, they've been able to beef up their mental health services in the school. They have someone come in 1 day a week, and that person sees 4 to 8 kids and families every single week. Yeah, so there's a definite need for that. So thank you for the opportunity, Ruben.
Thank you. Wow, that's amazing. The good these funds are doing out there already. So that's very, very impressive. Dr. Martin, I'm going to put you on the spot. You stepped out when we talked about Kansas County, and Susan Grindle was not able to make it. We're hoping that you are somewhat familiar with what they've been doing so far with the funds.
Yes. Right now it's still in development stage, but Hope Source, which provides a lot of transportation services in our area, is working with Elmview, and which administers Meals on Wheels, and Fish, our local food bank, to bring medically appropriate meals to those with that lack access, primarily because of transportation or mobility issues. But the kind of exciting thing from my standpoint is that we're not just talking about bringing whatever they can fix. We're talking about if this is somebody who's had a stroke, or we're bringing a pureed diet. We're building that infrastructure is what the money's being used for. And I'm excited to see where it goes. One of the other things that we're looking at doing, thanks to ACH support, is, again, with the digital health commons, how can we use that as a tool to coordinate the work that's being done around social determinants? So it's getting off the ground. We haven't started providing service yet. I think we're about a month away.
Thank you. Okay, so now, again, last but not least, Becky, representing also the Women Hospital Foundation.
And so I have my other hat on now. My daytime job is a grants manager for the Pullman Regional Hospital Foundation. We primarily support the efforts of Pullman Regional Hospital through fundraising and grant support, but we were able to work with the Whitman County Health Network to serve as the third-party administrator. I mentioned before that the Whitman County Health Network had implemented supported the implementation of the CLEAR program in one of our local schools in Pullman. One of the challenges with the CLEAR program was that it was fairly expensive, and we were looking for a
more affordable way to expand the trauma-informed practice programming countywide. So when we were awarded money from Greater Columbia, we looked at proposals and awarded a grant to actually WSU Extension, another program that they have called Strengthening Families. And Strengthening Families, and I'll let our grant recipient talk more about it, but it really works to train families or educate families and students to be more resilient. So it really works with resiliency, and so we are able to expand that education and programming nationwide. So I'm going to turn it over to Laura Rabel.
Thanks, Becky. Forgive me for my notes here. So thank you, Ruben, and thanks for having us here. I'm really excited and proud to represent the Strengthening Families Model 10-14 in Whitman County. One main reason, the family is near and dear to my heart, as is Whitman County. I lived there many, many years, moved away, and I've since returned back. With that being said, there's a fact sheet on the front table. If you grab that, the facts of this program really speak for themselves. This is the second prevention program that I have represented, and when the position came up for me, I really jumped on it because I've seen the benefits of prevention programs, as I'm sure you guys have. And it's great to catch the problems on the front end. It's an evidence-based model. It has over 20 years of research and data backing up the benefits of the program. It was created by Iowa State University. It has been implemented in Washington State since, I think, 2005 or even longer. Ana Maria Martinez has been working closely with me, mentoring me. I am an employee of the hospital, but also reporting to the Whitman County Health Network, et cetera. So, it's kind of cool to see how all these players have come together to bring this program to the county. Pullman is a unique community because it's got the university there. It's not your typical rural community. But then when you go outside of Pullman, you get into rural America, and it's two different worlds. So the way that I see the program going, and I'm going to give you a quick update in a moment, but it's kind of having to be done in layers. So I came on and was onboarded in July, so barely 3 months ago, went through onboarding at the hospital. So my goals have been to start in the inner circle in Pullman and reach out to community players, schools, churches, different organizations that work with children, 10 to 14, and families. So I've been targeting those groups for meetings. There's been a lot of great success. This program, what it does is it brings about 7 to 12 families together. They go through an 7-week sessions with 3 facilitators that are trained. You have to be trained and certified through Iowa State to present this program. So the grant actually required for my position that I'm going to implement that 10 times in Whitman County this year. So being that it's never been to the county and no one's ever done this, this has been sort of, for me, it's like creating, launching, how do you bring this, this program into a community. First great success I'm really happy about, we had a facilitators training at the end of September, which was pretty exciting to me that in 2 months of, we were able to kind of pull that off. We had about 11 people went through, got certified, myself included. It was really awesome. Ana Maria is a great trainer. She was really excited by the individuals, really leaders in the community. There were 3 teachers, labor and delivery nurse, a couple mental health counselors, a life coach. So really qualified individuals went through this training, and they'll be the first facilitators to take the program out. Being that there are 10 deliveries required, the next step for me was getting out into the schools, and for the schools are really like the best buy-in, right? So I've met with the assistant superintendent recently, you know, every meeting I've had has been really great because it leads to another meeting. So she got me then into Lincoln Middle School, who has now invited us to hold, the trainings will be, at least for Pullman, at that school. That's also led to a meeting I'm going to speak to counselors tomorrow. So it's really just been awesome, like what has happened. Another cool piece is I went to Colfax and met with the county health director, Troy Henderson, and he connected me with people I'm still working on setting up meetings, but more out into the outer community. So Azalea, Oakdale, Garfield, Palouse, food banks, libraries. So again, every meeting has been really significant in what it's done. So I would say that we're totally on target. The first delivery is coming out a little bit later because it's going to be in January instead of, my first hopes were October, November, but with the holidays, there's too many vacations, it doesn't work very well. So, I think that's really the only barrier that I would say has really come up at this point. My contact is on the back of this sheet, so if you have anybody that you think would be a great facilitator in the county, I'm looking for people that are out in the outskirts to lead in their community. So that's going to be, I think, probably a challenge, but we'll make it happen. But if you have any referrals, it would be awesome if you send them to me, and thanks for your time.
Does that conclude our formal presentations?
Yeah.
10 minutes at a time.
You can move on to comments and questions.
Yeah, so we've got about 10 minutes to give feedback or ask questions of the four panelists. Any quick thoughts? That's Ms. Moser.
I was just wondering how you guys are going to measure the success you're having.
So the question is about measurement, how that will be done. Given that some thought, anybody want to take a stab at that?
Let me try it. I think the measuring has to do mostly with reporting and being accountable. But when you say measuring, especially in a healthcare context, that means a whole lot more in terms of data and surveys and scientific standards and on, which I respect very much. So to the extent that we can and will be accountable for how the money's spent, because I know all of our grant recipients are, we would definitely be tracking that, sharing that.
Other thoughts?
One of our measures is the number of families and students, and then the number of people who are trained to facilitate those strengthening families programs.
I think I would, when I think about measurement, part of the reason we switched to more of an interview format, again, we've got one whole time, but we really liked it the first time, is that we're trying to build rapport and trust with some of our grantees. There's an inherent power imbalance when you are distributing funds, even when you're distributing on behalf of someone else and your grantees. And so we're really trying to make sure that we are building rapport so that we can have conversations about what you've learned. I often find I'm more interested in the complete and total catastrophic failures of what you thought was going to be great and then did not work at all like you thought it was going to. But more importantly, what did you learn? What else do you need? How are you going to redirect and still get there? Which, again, is a little bit of a luxury that we have in the philanthropic space as compared to some of the, when I think of medical providers and reports and numbers and that kind of stuff. But so we're trying to really build in some components of learning, adapting, and moving ahead as it is with our training.
I would also add that part of the program implements pre and post surveys. So when they attend the sessions and that first session, they do a pre-survey that asks some questions, and then at the end of the 7-week unit, they do a post-survey. So we'll also have that data on what they learned, what kind of tools and resources they were provided.
Other hands? Okay, I want to ask a question. This is a point that Roseanne brought up about sort of a bit of overlap, duplication perhaps of missions among the community-based organizations. Do the rest of you on the panel, do you face those same concerns that we see here, that Roseanne sees here at the Three Rivers Foundation? And if so, how are you approaching that?
Yes. I would say the short answer is yes, around duplication of services. And I don't, one of the things I really love about, and this will be a little bit more about Yakima County than Kittitas, but one of the things I love about Yakima County is in many ways it's big enough that there's usually multiple agencies offering similar services, but not so big or so resource rich in some ways that we have as many turf issues as sometimes I observe in other parts of the state. That is not to say they are not always, turf or territory issues, but really there's been a lot of really deliberate and concerted effort to try to coordinate where you can. And so even some of the things that were funded in our pool, our coalitions or networks, just like this one, because they're so powerful in helping to understand different services that people are offering and how to build strengths. And so as a community foundation writ large, we have a lot of different initiatives that are really based in networks, and we're trying to, and those are complex and fast-moving organisms, and so we're always trying to learn how that works, but we're trying to do as much of that as we can to try to get to some of that duplication reduction. We don't want to come in and say, well, we know that, and try to dictate what any organization is doing, but instead try to highlight commonalities and where we address philanthropy not with a scarcity model, but an abundance model of, increasing philanthropic behavior for one organization actually helps for all of them, which is really, that is difficult to live into sometimes because it does not always feel that way.
Carrie.
Patrick, I don't see it so much as duplication. There's a lot of organizations doing similar things, some doing exactly the same thing, but that's not as if there isn't a great need. And one of the beauties of our region, and I think everybody here can say that we live in a very collaborative community. For rural, you have to, and everybody's wearing 9 hats. It's like the high school senior that gets to star in the play and be, on the football team and all kinds of things. So that hasn't been a thing. And people, my impression, I'm an outsider, I'm a newcomer. My impression is that people really know and respect each other and welcome and embrace people trying to work together.
All right, and that's coming from Minnesota, the land of Lake Wobegon, where everyone gets along, Carrie.
Hey, I'm from Portland.
I would say along those same lines, I don't know that we have a duplication of services in Whitman County. I think we have a duplication of challenges. What we saw was a lot of different agencies had the same issues, or they had clients with the same issues, whether it be housing or food or access to healthcare or transportation. That's where we have duplication, is the challenges. And so we have limited resources, and like everybody's here, even in the larger areas, there's limited resources, and we all needed to work together and collaborate, and that's one of the reasons why the Whitman County Health Board was formed in Whitman County, was to facilitate those collaborations, and so that we could address those same challenges that Community Action Center had, that our primary care clinics were seeing, with the hospitals were seeing. And so I would say we have addressed those pretty well. There's a lot of work to be done, but it's not really duplication of services.
Okay. Last question, then we're going to just have it open to anybody who wants to bring something up. Okay, well, you can stay up here if you'd like, because we're just going to have a give and take here for 10 minutes, we hope. But before we say goodbye to the foundations that are before you, I just want to make a comment from my observation of working in this space for the last 15 years, how lucky we are to have community foundations. I've been so impressed over the course of my career to see just the good work that community foundations, and not to forget a hospital foundation. These are not just pass-through entities. You can see a lot of the pairing of common interest that went on between the ACH ostensible goals with social determinants of health and what the foundations are really after as well. So I just hope we all treasure these remarkable institutions called community foundations.
Thank you.
All right.
So what I encourage you, I'm pretty sure that something piqued your interest. There's someone here you want to talk to, introduce yourself to. I encourage you to go ahead and approach any of us here to learn a little bit more about what they're doing. If you want to find out, there's a name on the back of the agenda here that you would like to contact, and if that person is here, we can certainly, the foundations can certainly point you out. But yeah, go ahead and learn from each other and introduce yourself to anyone that you're interested in meeting here. And Dr. Martin has some words.
Just wanted to point out that the contact information for GCACH isn't accurate. Susan Stoltz no longer on the board, so we'll have Robin Hendrickson Reed as our executive director for information on the website.
On the back?
Yeah.
But she's still with Hope Source, right?
She's with Hope. She's CEO of Hope Source, but she's no longer on our board. Her term was up.
We have her here as a grantee recipient.
Okay, that's accurate.
Okay.
But she's just not us.
Yes. Okay. Well, let's mingle.
Mingle time. Thanks for coming. There'll be one last meeting. One last meeting on November 20th.
Rhonda?
Well, we're here. Yeah.
And that's been that the last couple of weeks.
Nice to meet you in person.
You're at a few.
Not